So actually, valve bladder in children is a topic of debate at the moment, because there are not much of things inside it. The four valves in the heart, we know that most commonly now we started to replace the pulmonic valve in children, and tricuspid valve most commonly if they had a valve implantation as early as 10 years of age. But mitral and aortic has been still a distant dream for pediatricians to replace it, because the growing children is difficult, and also technology is not as suitable for children for aortic and mitral. So I'm going to talk about pulmonic and tricuspid. Aortic and mitral has been mentioned in the literature only in exceptional cases where surgery is contraindicated, and more in older children, 16 years old, and it's off-label indication. So what I'm going to talk about on pulmonic valve and tricuspid valve. The limitation in children, as we know, they requires large sheaths. All these valves require 16-22 French, and sometimes it's difficult. Children is less than 20 kgs. Growing heart needs a valve which can be adapting towards growth. So we cannot be implanting small valves in small children. In small size heart, difficult to take, manipulate inside the heart, limited reserve, because patients could collapse with severe TR and other issues in the heart, and no calcifications to hold. Unlike in adults, we expect a calcification to hold. For the valve, there's no calcifications. So I'll quickly go on to pulmonary implantation. Mostly, or 100% patients are most post-op patients with RVOT. Rarely we do see patients who have had pulmonary valve ballooning who come for valve implantations, and most common indications are pulmonary regurgitation and pulmonary stenosis, and we know the indications of them. I'm not going to go through this. The criteria now at the moment is even the valves available, or the balloon expandable valve, Sapiens and my valve, and also venous P. The weight is more than 20 is the sort of criteria we have. And if they're less than 20, they're not suitable for a valve implantation because of the access problems. Per-ventricular route has been tried, but my talk is only on percutaneous valve implantations. So for a percutaneous valve implantation for pulmonary, we always use general anesthesia. We access the right inlet IJV and right radial artery for the anesthetist and right femoral vein for the primary access for valve implantation. Left femoral vein for RV angiogram, look for the positioning. Right femoral artery for LV pacing. This is something we do because most often we have big sheets across the right ventricle, and in a native PA implantation, the valve needs rapid pacing. And rapid pacing, once you have big sheets across the right ventricle, once the pacing catheter comes to right ventricle, we cannot position back. So I always keep the LV pacing. Either I use a wire to pace the LV or a pacing catheter. Left femoral artery, look for coronary angiogram, and also for interventions if required. So our experience now is we have done around 15 patient successful implantation out of 20. Out of that, 6 had children, and all had successful valve implantation. Range is 10 to 16 years of age. The weight is 23 kilograms to 84 kilograms. That's the range we have. Sizing the valve, the average size of the valve was 30.5, and this is basically the entire cohort we had, and most often the valve we use is 30 mm valve. Sometimes we have to increase volume to 30 mm valve to increase the size to 34 at least, to get a good dilatation gripping on the native PA. The hardwares we use, so we have diagnostic catheters, as we all know, 5 French jerkins and pigtail. Important hardwares here I would want to mention is the Lundergust wire, which needs to be deep in the LPA for taking the valve across, and you need to have the Z-mid balloon, which I don't use this compliant balloons. We need a hard balloon because we know exactly how much resistance the native PA is going to offer you. Covered stents and stent grafts and large size sheets. So going on to examples, this is a child who is 15 years of age, who post-etiology valve repair, who had a landing zone. So CT scan is done for a landing zone assessment. Anything more than 30 mm measured in a CT scan on average is not being considered for for a valve implantation, because it's not suitable at the moment for a my valve. But same time for a venous P, I think different criteria. I don't have much experience with venous P. My experience more with balloon expandable valves. Here you can see the average landing zone was 2.9. And one more important thing is you should look at the landing zone length distance from the bifurcation. There should be more than 2.5 centimeter, but here is only 2.12. That's an important criteria, which needs to be noted, because if you have it very close to the bifurcation, there won't be enough expansion for the proximal part of the balloon, and the whole system comes down. So you should have at least 2.5 centimeter from the bifurcation, because the balloon will expand proximally, and once if you don't have space, it will push the entire system down. And you can see there's a deficiency in this patient particularly. This is the early part of experience. So here you can see we do an angiogram in RAO 3030, LAO, cranial, and also lateral views looking for the landing zones. So we go for balloon sizing. Balloon sizing is done at rapid pacing. I always do on rapid pacing because it helps me to have the stable balloon position. It's very important for me to stretch the PA sufficient enough to make sure there is a good radial force, and I add up 20% to 25% more than the balloon sizing to go for the right amount of valve, and there's no coronary compression. And we never had a coronary compression in our experience post valve implantation. Only once we had an anomalous coronary artery which has got dual LAD, which is like a circle around the PA, which caused occlusion. Otherwise, we never had a occlusion in native pulmonary arteries. So the valve deployment is basically we take the valve. You can see here what happened is, as we are deploying the valve, as I told you, there is not enough space around the proximal part of the balloon to expand. As it expanded, you can see the valve is pushed down out of the native landing zone, and it went into the bit of a RBOT. At this point, what we realized is we may be down below the narrowing. So I took up 510 ml more than the volume which required. So expanded the valve to the maximum so that we would be able to secure that stent inside the RBOT. But what happened is it has severe pulmonary regurgitation post dilatation. So I took up one more valve inside, and then we deployed the valve, and there's a good result across. So very important what we learned. You can see the next valve implantation also. You can see as we start to deploy, the valve is pushed down, and I have to give a lot of force to push it up inside and then implant the valve. So the minimum criteria is 2.5 centimeter from the bifurcation is your criteria to go for a stable valve implantation, and final result was very good. The next child who is again a 15-year-old child who had a very roomy pulmonary artery, and it's about 3.2 on average, and the landing zone was quite close to the bifurcation. So here we felt we could not put the valve in the exact position, so we thought we should do a technique where we have a proximal anchoring in the left pulmonary artery. So that's why I planned. So this is an angiogram, and there was a mild obstruction. There was an obstruction to LPA. RPA, there was no gradient. So we thought we should go for a left pulmonary artery stenting, and then put a valve inside the in the closer to the bifurcation. The systemic pressure, RV is 80, aortic systemic pressure 110. The good gradient across the LPA. And we did a balloon sizing, and you can see there is no there's no tight fit. The PA is ballooning out, and so we have to aim for the valve very close to the bifurcation. So I took up a Zephyr stent initially. This is Zephyr stent there, which is I took a 57 millimeter Zephyr stent over a 20 mm balloon, and then inflated it. It's a ZMED balloon, and so I didn't go up maximum pressure, but it didn't expand further. So we took a Atlas balloon, which is about 24 mm Atlas balloon, which was expanded further. Once it expanded, we expanded the proximal bit also, and you can see that's the picture of the expanded stent with the proximal flaring, and you can see how well the fastener is sitting. Then we took the valve. The valve was a 27.5 valve, and it's expanded to the maximum, and that's the result force. So the anchoring force is from the stent above, and there's a good sealing of the pulmonary artery. The trivial PRs to centrally we have seen, and the PA pressure came down post implantation. The third example is a child of 10 years of age, smallest child had done, who had a MPA, which had a tracheal fallow repair, and had bilateral branch PA stenosis, and she is from Nigeria, and so she came along for a basically relief of the aortic obstruction and pulmonary branch P obstruction and significant dilated RV. So the initial plan was to consider bilateral branch PA stenting and send her away, but with a significant amount of RV dilatation, we thought we should try put a valve also. So here you can see the significant branch P obstruction, and so we did a bilateral branch PA stenting. We took two Zephyr stents, 20 mm both sides, and then we took the valve inside, and then finally deployed the valve, and so it's good result following. There is no obstruction, and the IV pressure came down post implantation. So the good immediate outcomes: safe to implant myvalve without pre-stenting, and we recommended 23% oversizing. And surgical valves, we have for the tricuspid we have valve in valves. So I'm going to skip through slides because there's not much of thing to learn from here. So here always anchor in tricuspid valve, we anchor the wire deep in the LPA just to give you idea. And once we know there's a app to tell you what is the right size valve to take for each valve, surgical valves, and we go for a very slow inflation and checking the position. We don't pace the heart, and you can see the faint line of a surgical suture line being there for the surgical valve. Then we go implant the valve. So this is basically it's the 18-year-old. It's not a pediatric age group. So summary: percutaneous valve implantation is feasible in grown-up children. Current technology is limited only for pulmonary valve implantation, maybe for tricuspid valve also. Aortic and mitral is still in evolution. Thank you very much for listening. Thank you.